Surgery, Bloomfield Hills, Michigan. Another Facebook Live. I thought this was an interesting one. So this is a patient that had lobular carcinoma in situ. So that truly is not a cancer, but nonetheless, she ended up getting in 2005 what is bilateral mastectomy. And she ended up having what is a latissimus flap. This is the latissimus muscle in the back that was brought up into the front. The implant was placed above the pectoralis major and then followed by the latissimus that was covering the implant. So basically pec major, implant, and latissimus flap that was brought up from the sides. So she interestingly had what was a MRI that was done that showed that both of these implants were indeed ruptured, and hence her concern for doing an explant. Now what's interesting is she went to her plastic surgeon group, which I will say is like the top 5 in the country, if you will, and she was told she has 3 options. Option number 1, remove the implant and replace, having known that both of these were ruptured. Now option number 2 for this 75-year-old patient was to do nothing, to live with a ruptured implant, which is a big no-no. And for a 75-year-old patient, option number 1, to get them both replaced, I think that was not a smart or a wise idea, because you don't want to deal with this if she's 85, correct? Because they last only 10 years. And the third option, which they did not recommend, was to remove the implant because she would have severe quote-unquote ptosis amongst other problems. Now the bottom line here is someone 75, in my discussions with her, ultimately this is her decision. The goal was to remove both of these ruptured implants and to contain all this inflammation. And so we'll see the MRI reads both the implants with intracapsular rupture. That means all contained within the capsule. This was a while back when she had the MRI. So as you can see, she had what was a flat chest aesthetic closure. MRI said both of these implants ruptured. She has this right mastectomy flap with the skin paddle that has been stitched at 12 o'clock for orientation. So this is lateral, this is medial. You can see the thinned out area underneath here. Very thin compared to this thick, and she has a little bit of a higher BMI. So as you will see, this implant completely removed definitively with irregular hard mass. As you can see, actually this is like a irregular hard mass. I'm going to cut right through this. Maybe, who knows, this might be an extracapsular rupture, irregular mass. So anything that looks bad, palpates bad, feels bad, my sixth sense says is bad, is removed. Because we do not know if that might be, God knows, cancer. You have to always think that. That might be an extracapsular rupture. Maybe the MRI was wrong, or back then when the MRI was done, it was intracapsular and now became extracapsular. So anything abnormal, irregular was removed. And, so we will see what it shows and if the MRI is correct or not. And then I just want to go ahead and show this mastectomy paddle for the flat chest aesthetic closure. This entirety was removed. It's going to go to pathology, as we'll talk about shortly, given the history of LCIS, which is lobular carcinoma in situ. So let's find out. 20 years later, she is in 2005. So technically 21 years later, LCIS, lobular carcinoma in situ. She had what was bilateral mastectomy, bilateral latissimus flaps. And let's go ahead and see what this shows. I'm actually going to go ahead and go right through this area. Just curious to see. You can see how hard it is, right? So irregular hard tissue. And let me go in now. So remember, back in 2005, they were doing reconstructions just for with silicone implants for cancer patients. What's ironic and interesting, because whether you do it for cosmetic or reconstruction, they're the same implants that are going to rupture. So why permit it in reconstructive purposes? Because as you can see, this is indeed a ruptured implant. And we saw earlier, this is not like the first case that I did today, but as you can see, this is relatively speaking more contained than the one that I did earlier. And as you will see clearly, this is a ruptured implant. You will see the amount of inflammation present. And none of this spilled into the chest, no need for drains. and she has what is a flat chest aesthetic closure. And let's go ahead and look. 450 mentor implant. And let's go ahead, and if I were to press here, you'll see that's where the rupture is. So the shell is made up of a different material than the inside. And again, none of this built into the chest. She got the surgery she was looking for. Her one and only set. She had tissue expanders placed. She had bilateral latissimus flaps. And a lot of inflammation on the right side. So the MRI indeed is correct. Now I have a new pair of gloves. Same thing, flat chest aesthetic closure, left side, left mastectomy flap with the stitch at 12 o'clock to orient. This is the lateral, this is the medial. You can see how much thinned out the tissue is, and a lot of fatty tissue. And you will see right here, complete 100% total capsulectomy. And remember, according to the MRI, both of these are ruptured. So let's see what this shows. A lot of inflammation. You can see how thin the flap is. No matter how thin, the entire capsular tissue implant, all inflamed tissue, this inflamed tissue around has already also been removed. So this is very interesting. So the MRI is wrong. This is an intact implant. So the MRI is wrong. And 400 mentor, intact silicone implant. 400 mentor silicone implant, as you can see, intact silicone implant. And this is the capsular tissue, the entirety of which has been removed. You'll see how thin some areas are. No matter how thin, you can see my green glove. The silicone implant was sitting right here in this pocket, and the entirety of this capsular tissue has been removed. The other thing I want to highlight is this yellow fatty tissue right behind has been removed as well, in order to completely remove all of the inflamed tissue. So I was thinking this was going to be ruptured as well, and again, you never know what you're going to find out till you go inside. So the implants will be returned to the patient, capsules to be sent to pathology, rule out the rare BIAL, CD30 analysis, rule out lymphoma, rule out malignancy, cultures for Arabic, anaerobic, and fungal. We have the right and left mastectomy scars, which will be sent separately to pathology, given the history of LCIS, lobular carcinoma in situ. No need for drains. She's going to have what is a flat chest aesthetic closure. I'm overall very pleased, very happy. The point here with this Facebook Live, YouTube Live, is the MRI is not 100% accurate. It is the best test out there. If you look at the mentor guidelines, they tell you get an MRI at year 3, and then every 2 years they're onward. So she's had them for 20 years, so she should have at least 9 MRIs looking for a potential rupture according to the mentor and FDA guidelines, at least the mentor guidelines. The newer guidelines by the FDA are more practical, but according to the mentor, you will see they tell you to get an MRI at year 3, and then every 2 years they're onward. I could not have done it any better. Everything contained, no need for drains. And we will see how the patient does, minus a lot of heavy and ruptured implant on the right, heavy implant on the left removed, minus what are the signs, symptoms of what is suggestive of breast implant illness, and we'll hear from the patient in regards to her ultimate recovery. This is Dr. Khan, Executive Plastic Surgery.